introduce Christopher Palmer. Christopher is an associate professor of anesthesia, critical care, and emergency medicine at the Washington University School of Medicine in St. Louis, Missouri. He's also the co-medical director for the Barnes Jewish Washington University ICU telemedicine program. He has a keen interest in emergency medicine. During college, he was an EMS, EMT, and he stayed on at WashU, where his initial career and residency at a fellow education and collaborations and research projects. His niche is in emergency critical care with focus on ICU telemedicine, which was launched in 2016, and he serves as a leadership in it. Today, he's going to talk to us today about the transforming healthcare in the digital era and the telecritical care. So thank you so much, Chris.
Appreciate it, Evan. Can you hear me? Just making sure.
Yep, everything sounds good.
Sounds good. Okay, so today, appreciate the introduction. Excited to talk to you guys. I get to talk today about something, I'm just really passionate about. It's a hobby of mine, but at the same time, it's also my job. So it's a nice little merging of all the worlds there together. Talking about technology and in particular today, like how I see, the field of medicine evolving over the next 10 or 20 years into this digital health era. And I'm going to focus today primarily on telecritical care and the operation that I help run here at Washington University in St. Louis. So my objectives for today are, I want to start off a little bit of a primer on what I like to try to do myself is like really exponential thinking and talk a little about some of these disruptive healthcare technologies that are present today and also coming down the pipeline and talking about a little bit about what we really struggled with over the past, nearly decade now of, dealing with this new technology like telecritical care and the bias and the inertia and the fear, surrounding the unknown and kind of doing something novel and different, but in hopes that it would improve patient care. And at the same time, then I'll move into a little bit about just, the majority of the talk mostly on telemedicine in general, but specifically our program at WashU and BJC and what we're doing today. My disclosures, I know you guys are in New York or New York City, so I grew up in Binghamton, New York, or Vestal, New York, which probably many of you know. I just visited New York City about a month or so ago. So massive Bills fan, big game tonight. So go Bills if any of you are Bills fans as well. The more important disclosures is that I am a seed investor in a telehealth company called Omnicure. I won't be speaking at all about them today. And also that, I am a linear thinker. I have no clue what the future holds. I'm always trying to predict it and be a step ahead. But linear thinking generally gets me in trouble. And when I try to get people to understand exponential thinking, this was always the graphic that stuck with me in terms of, well, what is exponential like thinking in general? And, if you ask someone, how many times does it take to fold a piece of paper over for it to reach the moon? I don't know. When I first heard this, I was like billions, trillions, like I don't know, like some astronomical number. But it's only 42. And from that standpoint, it just like kind of blew my mind in terms of like, well, it's not really even possible to fold a piece of paper over 42 times. But if you could, it's really those folds like 20 through or, 20 to 42 where like basically the rate of change and the growth curve goes exponential, just kind of like compound interest as one of the eighth wonders of the world, basically. And so I always try to apply this type of thinking to my life and to my career, and kind of like try to always zoom out and step back and like, where are we, in the field of medicine? And I truly believe, that we are kind of at that fold 20-ish or so, something in there where the early years, going back all the way to the beginnings of medicine and bloodletting and germ theory, and maybe towards the beginning of my career in residency, 2008, where, we're doing BiPAP on patients and thinking about ECMO and TPA and now TNK, like all this kind of stuff, I feel like is at that flat part of the curve. Because even nowadays in mid-career here, I feel like I can barely keep up with all the changes that are coming about and all the different novel therapeutics that we have at our disposal. And I really think it's like just hitting the inflection point in the next few decades are going to be, really just astronomical in terms of like how our profession is going to change. as we really enter this fourth industrial revolution, really the digitization of everything, which includes healthcare. Software is eating the world, and medicine and healthcare is not any different. And how we combine all these new technologies with AI, augmented reality, big data, cloud computing, mobile devices, smart sensors, you name it, in terms of our industry and how we're going to be able to impact patient care, I think is just something that most people cannot comprehend. And these are extremely disruptive technologies, and telehealth is one of those. And I get to personally, work with that. Well, not every day, but during my ICU weeks. But as well, we're using these technologies, and I don't know if you guys are, but these are things that we're using every day. Like we don't necessarily have to write notes anymore. We just have our AI scribes just listen to us, just to focus on the patient, step out of the room, and the notes already generated for you. Soon enough, it'll be placing orders that are common to me for what I anticipate the patient will need. These technologies, in terms of being able to monitor maybe 3 to 6 patients across state lines, hundreds of miles away, all from sitting, in my own chair at our telecritical care center, is truly remarkable. And doing it 24/7, 365, and using our alerts. That kind of help direct us to patient care, saying, hey, this patient's probably going to have some hemodynamic collapse in the next 12 hours. You should look at them. The signal is there. We're flagging concerns and signs for sepsis, actually even cardiac arrest. So something's off with this patient. We need you as the physician intensivist to take a look at that patient. Or as well, just in terms of our education, our simulations, using augmented reality. Some of our professionals are using these tools to assist them in procedures to make them a little bit more highly the fidelity even better. And some things that I know probably we've all experienced in our own life in terms of the vaccines, and how when I was on meetings in 2020, everybody said, well, there's no way we're going to get a vaccine for another 5 to 7 years. It just takes too long. And then 3 to 6 months later, I had a shot in my arm, and the country was back open, and we're off to the races. Due to some of these incredible new technologies, that what we thought was impossible is becoming possible. And it's all because as technology improves, costs go down. It used to be $100 million to sequence your genome. Now it's a couple $100. You swab your cheek and you send it in the mail, and you can get your genome sequenced, basically at the cost of, like something quite cheap. And this is really just the beginning of this. I haven't even spoken really much about, Chat GPT and AI, but we're now at the level of human intelligence, and generally on this pretty accurate curve by the year 2050. You're going to have on your cell phone, basically on your iPhone, for the cost of an iPhone, you'll have the equivalent of every single human being's intelligence basically at your disposal on your iPhone. If this technology continues to go exponential and compound, as it seemingly has, since, like basically the early 80s and 70s. And again, we see this here today in practice. I got this alert from the radiology a few months ago that basically said, hey, our AI service overread the Nighthawk services read, and there's a concern for an epidural hematoma in the lower cervical upper thoracic spine. You probably should get an MRI. We got an MRI. There was an epidural hematoma. Outcomes certainly changed and differed because we're using some of these technologies that can improve our patient care. And what it leads to and where it goes, I don't really know, in terms of AGI and the singularity and Skynet and all those things, as I date myself from a Terminator standpoint. And I choose, instead of being scared, to be excited, to look on the positive side, and recognize that when, one of the largest company in the world, their CEO is basically saying, hey, digital biology is the next frontier. We're going to be able to take biology and turn it, into engineering, and we're going to be able to compound the effects of our learnings over time, and really mathematically understand like how biology works, and really turn it into a digital nature that we can replicate and study. It really kind of gets me excited about how we can impact patient care through more precision medicine, and kind of turn us into, the caveman into maybe a little bit more of a modern day, human kind of doing incredible things. And there's some issues with Minority Report that I don't particularly want to go down that road, but I thought some of the technologies there are pretty cool. And it doesn't honestly matter what I think because I truly believe nothing stops this train. This technology is proving to be incredibly valuable. I use it nearly every day. I see the effects, I see the value, I see the cost savings. And when those things line up, nothing stops this train. It's coming whether you want it to or not. Just kind of like when I started using ultrasound in my early residency days, and everybody saw the value and the impact on it. It's like, well, okay, this is going to be a big thing over the next 10 or 20 years. And sure enough, now, you use it every day, and it's almost a prerequisite to be an attending physician after you leave residency. And so I encourage people, especially with telecritical care, telemedicine, that many people they are afraid of it. They don't think it can possibly work. And I say, just don't be a Luddite, right? Try to embrace new technology. If it's inevitable, try to be an early adopter, acquire the new skill because it's coming, for you to try to benefit patient care. And I think as we adopt these new technologies, we're going to be a lot better at curing diseases, precision medicine, morbidity, mortality improvements, hopefully better in preventative medicine, longevity, access to care, right, in terms of equity, and hopefully allowing us to really have a much more deeper patient connection as maybe we step away from the computers so much and actually can, just focus on the human being in front of us. And so my roadmap for the rest of the lecture is, to talk about our specific journey with telecritical care and that novel technology, that medicine, that the technology that we saw coming down the road in terms of being able to impact, our region, our healthcare system, and why we thought it was so important, and kind of like what we've done as a program at BJC WashU and what the future state is looking like for our program. And I like to start off, just generally like, so why? Why telehealth? And obviously, there can be so many different reasons. I usually find that personal reasons land with people the best. My father turned 65. I don't know. He went on some sort of white water rafting trip and bonked his head. And he wasn't on any blood thinners, but he got a subdural. And he's in rural upstate New York, Vestal, New York. Maybe some of you, again, know where that is. But like he doesn't have the luxury care maybe of being in an academic, tertiary quaternary care center. And so he got, his subdural evacuated, but he had a ton of complications afterwards. He was in the ICU. The neurosurgeon basically rounded at 4 a.m. for 5 minutes. And from there was no intensivist. I think there was a hospitalist and, you know, just unnecessary antibiotics, no DVT prophylaxis, on random, medications that didn't make sense, beta blockers, dopamine. Like it was just, he wasn't sleeping, just nonsense. So I literally had to fly up there in order to basically try to figure out how to, help him through his post-recovery journey. And it was very taxing on me, my family, my kids. And I just wanted to take care of him from my own home if I had access to, a camera and his electronic health record, as I do here today, from St. Louis, but I couldn't. And that to me was a very eye-opening experience of like just how positive, telehealth can impact, patients, including my own family members. And when I think about like what our values are at BJC, WashU, we want to really deliver customer-centric, frictionless, high-value care. We want to be a leader in quality, a national leader, safe, effective, efficient care. We want to be large. We want to grow our presence, scale, and scope. We want big market share because which drives revenue, which drives, our ability to, pay our employees better and bring in more talent. And at the same time, community health improvement. We want to eliminate those health disparities and really offer equal access to our outstanding physicians, no matter where they are. So instead of that message of come to us, well, we're trying to spin that to be like, no, no, we'll come to you. You don't have to leave where you are. We will bring our expertise to you, to your hometown, with this new technology that's available to us now. And I think that really resonates with people because they're like, wow, that's awesome. Like I certainly want to go to that hospital if I can get access to those experts, but I don't have to leave my home and go down to Big Barns in the middle of St. Louis where, some people just don't want to go. They don't want to travel there. And so those are some of the general reasons, and we'll talk about more of these a little bit more specifically in terms of the quality and the value and the safety that telecritical care can provide. how scalable it is because it's telemedicine and it's digital, the efficiency that we can, bring to our system with telecritical care, the health equity, as I just mentioned, in terms of, bringing this technology out to rural community areas who have never seen basically, an academic, a quaternary care physician, highly specialized, highly trained, in their rural community. And also, incredibly important is those secular trends that we're all facing. I don't care where you are, what region of the country, we're all facing these things. And as I mentioned, my father turned 65. And the baby boomer population, is just in almost its infancy, I would say, in terms of like really starting to impact us in terms of volumes, right? In terms of this baby boomer generation, they're turning, becoming 65 and older every single year. We're kind of in the midst of it here in the 2020s, and it's going to continue on throughout the 2030s. And so this general population, our healthcare system was never designed, never set up for this in terms of caring for, very elderly patients into their 80s, 90s, and longer with incredibly high acuity chronic health problems. That at the same time, we're kind of dealing with a workforce labor shortage that is very drastic and very challenging. I'm good friends with our program coordinator, and getting critical care fellows is not as easy as it used to be, especially after COVID. We are going to have a pretty dramatic intensivist shortage here over the next decade or so. There's no way that, again, we can even get an intensivist out to a lot of our rural hospitals in Missouri because, a lot of the young faculty, they graduate, they want to be in a major academic center. You can't pay them enough basically to move out there, and staff a small rural community hospital. Meanwhile, many intensivists are retiring, because of the baby boomer generation. So we have this like dramatic diff, problem in terms of workforce, people exiting the workforce, and at the same time, less intensivists coming into the workforce. And as I, age myself I consider myself a boomer millennial in terms of like being a very early millennial. Like I still resonate with millennials in terms of saying, hey, like this is what I demand. This is what I expect out of my healthcare. Everything that I can do is basically virtual. I have a family, I have kids, I have a job. Like things need to be on demand. They need to be timely, convenient. And I want the quality there. I want the value there too. And a lot of the things that we do are mobile and on the go. And so if your HSO, your institution isn't offering telehealth, well, then your competition is. And so and you're basically going to start going to where you are treated best, where you find the most value. And I really do believe that in terms of even in my own life, I look for that in terms of like who I'm seeing to provide me the most cost-effective, highest value care. And telecritical care and what we offer as a system at BJC and WashU is no different in terms of the outcomes that these hospitals expect in terms of morbidity and mortality and patients. This is publishable data, and they know where to go, where you're going to have the best chance of survival. And so we want to help our hospitals basically deliver this, much more value-based healthcare instead of maybe that fee for service. Like we're really, trying to focus on lowering costs. You get one payment a lot of the times. You got to make sure that your outcomes are good as everybody splits up that payment. So the models of healthcare are just changing drastically, whether you want them to or not, basically now and into the very near future. And so this kind of tsunami of problems and secular trends, as this hospital looks a lot like Barnes Jewish, is really coming towards us with the boomers, with their chronic health conditions, the bed shortage, the hospital closures that I'm experiencing. I'm sure you guys are. Can't even discharge patients to skilled nursing facilities and rehab facilities because there's a labor shortage, burnout, costs, reimbursement, the inequality, the trust issues after COVID. Like all of these things are very dramatic and are very complex. And they're at our doorstep if not here. And so we have to find a way basically to deal with them. And I look at telemedicine and telecritical care as kind of like our fork in the road where we say, hey, like, we don't change anything and like we're just going to slog through this and try to get through the next 20 to 40 years and see if everything resets. And it's going to be hard. Or we pivot to something that maybe is a little bit novel, it's different, but it's drastic and it maybe can help mitigate or help solve, some of our problems, not everything. And I think that is in that realm of telecritical care and AI and efficiency. And so that's what we looked at basically, what is it now? About 10 years ago now, in July of 2016, we, had our ribbon cutting ceremony for our telecritical care operation. And I think we've had really just exponential growth since then, things that I didn't even really anticipate. But what we wanted to do is like build this critical care program based on on quality. That was like really, our mantra at the time, using new technology and processes to say, hey, we want to have quality critical care everywhere in our entire, BJC healthcare system. We want to be much more data driven and evidence based. We need to create some standardization and efficiency throughout our hospitals. We need to build more capacity, but we can potentially do that through better distribution and level loading our system. And hopefully, these optimal clinical outcomes will also lead to improved financial outcomes as well, primarily through cost savings. And so that was kind of like our driving force, and some what we were trying to do, about a decade ago in terms of the vision of seeing like how are we going to solve some of these problems that were inevitable at the time for us. And our partnership basically with WashU and BJC, we're kind of one entity that, as we work together, is we now provide 24/7, 365 clinical coverage of about 275, maybe a little bit over 300 ICU beds across, I think it's like somewhere around 10, maybe up to 12 hospitals in our BJC system. And it's really the extension of intensivist expertise to these BJC community sites, many of them without in-house intensivist services, where it's primarily a hospitalist, sometimes an APP, depending on with variable critical care training. And we facilitate really the standards that we set at BJH, our kind of the main flagship hospital, out to all of these community hospitals, things that we know improve outcomes for critically ill patients. We, have them, patients have around the clock access to experienced ICU nurses. So hopefully the junior ICU nurses have someone that they can rely on at all times to help them, as maybe they've newly graduated and they're by themselves at night, and, hopefully to mitigate mistakes. And hope, the goal being to reduce mortality, improve our preventable harm metrics. We want to retain high acuity patients. We don't want them to leak out of the system and go to other health systems because they basically have a bed availability issue. And a lot of that we're doing kind of with a collaboration with our transfer center. We look all of these things through a much more data-driven performance improvement than we did maybe I'd say a decade or so ago. And so, these are all the hospitals that we are covering now. We just brought on our last hospital in the BJC system maybe a few months ago, Memorial Hospital. And, again, exponential growth. We started with 2 units at BJH, our CTICU and our SICU, maybe 30, what is it, 50 beds or something to that effect. And then throughout the decade, just like opportunities arise and you grow and grow and grow and grow as people find value in what you're providing, and how you can bring high level quality care to our hospitals in all of our region. And many individual, like a lot of people don't have a tele IC. They've never experienced it. They're not sure exactly what it's capable of. And so it's generally just it's simple enough in that we have a virtual presence in all these rooms where we have two-way audio video. And I'll show you a picture of that here in a second. And we have, at our we're not working from home. We work in a kind of a spoke and hub and spoke center where we're all kind of together, and we have clinical data that you would have at the bedside at our fingertips in our control center. And we basically from telecritical care kind of assist and or direct care depending on who's at the bedside and what time of day it is. We use a lot of AI kind of decision support tools to help direct our attention to patients that may be falling off trajectory, because it's a little bit more of a population health mindset when you have 300 plus beds. You can't know everything about everybody. And so you're using some of these tools to really help focus your attention. And then we, again, always are trying to look at our data, really leverage the voluminous data that we now are able to collect throughout our entire system to try and identify outliers and drive improvements and find out like where our weak points are, to improve basically both not only quality care, but as well as just our efficiency and how we're able to open up beds and bring in more patients as at a time in a timely manner. This is a picture of me sitting in the telecritical care center. As you can see, you basically have all the tools, like you have telemetry, you can get access to, all the images. The camera is up there in the middle, which allows you to basically not 360 degrees, but it's a pan tilt zoom camera where you can zoom in. You can see, the size of a patient's pupil, the color of their iris. You can zoom in on the vent. You can zoom in on the infusions. You can see absolutely everything that you need to see. And you basically, it's like you're standing at the foot of the bed. And I tell most people that, I don't know, there's no exact percentage on this, but probably 90+% of what I do as the intensivist is I just direct care. I'm not doing many of the procedures in the academic hospital, but still, it's like, okay, I need you to intubate. Please place a central line. Please place an IO. Please give epi. Please give these antibiotics, et cetera, et cetera, et cetera. Sometimes I'll have the bedside provider, even if they don't know ultrasound, I'll have them put the probe on the chest and I'll tell them, please turn this a little bit this way so I can see maybe some visualization of the heart if I'm trying to get, some sort of estimation of their ejection fraction. So I can almost do everything that I need to do besides procedures, from the camera. And it's really just like an incredible feeling when you're able to, take a patient from the throes of death, basically, at a small community hospital at 2 o'clock in the morning where there's no help, and either stabilize them and keep them there, or stabilize them enough for transport to your quaternary care center where basically they can get, the help and maybe procedure or whatever that they need. And so those have been some of my favorite and best and most memorable saves throughout my career. And on the provider side, all they see is basically just my face, basically on a camera. And we have mics at the top of the room, so they just talk normally, but they just literally like talk to the camera. It's kind of like FaceTime, and it's really not an issue for them. When we enter the room, we have a doorbell, so they know that we're there, we're present. And again, on our end, it's a little bit different in terms of what we're looking at in terms of individual patients, and it's a little bit more of a learning process in terms of like maybe what most people are typically used to. But we have all the data that we need to, figure out like what's going on with this patient, get as granular as we need to, start a video session as we need to communicate with the patient or the bedside nurse, do what we need to do, use the AI, use the tools that are kind of flagging us for concerns. And ultimately, we hope this is just like, in that Swiss cheese model, basically another layer of care to kind of prevent mistakes, prevent complications. As, things are commonly missed at the bedside, things fall through the cracks. But if we layer in the tele ICU and telecritical care into that operation, it's just another chance that we're able to prevent, a mistake from happening or a bad outcome, or find things early, to get them basically stabilized and get them the care that they need. And I look at this as really this kind of like it's a care traffic control center. Maybe not the entire time if there's an intensivist at the bedside. I'm not necessarily flying the plane, but I'm helping to kind of like point them maybe in the direction that they need. I'm there for a second opinion. I'm there to kind of offload them if they're super busy and they get like 3 admissions. Maybe there's something else that I can do for them in the meantime, just to ease their load, ease their burden, but make sure that the patients are doing as well as they can. And it's very difficult, you'll see in the literature, to like prove that this actually like reduces mortality and basically has all these dramatic effects. But I also look at it like the pulse oximeter and ultrasound, where it's also in the literature very difficult to like prove that these things decrease mortality on a statistically significant basis. But all of us basically at this point can't imagine our lives and our jobs without a pulse oximeter, without using ultrasound, because it's a tool. And if you use it to your benefit and to enhance the efficiency and your ability to take care of patients in various ways, it's something that you never like want to be without. And when I'm at the bedside, I also use the telecritical care for various things that I find like makes my day easier, but also I feel more confident in the care that I'm providing for that patient. And one thing that, again, the inertia, the bias, the fear, oh, you're going to record me and you're going to play back my mistakes and you're going to basically like get me fired. Like we don't Big Brother anybody. We don't record. We can't record. We can't do any of that. The goal is really just to help take care of patients. We're another member of the team. We're just virtual. And that culture change takes a while actually to build the rapport with a lot of these outside hospitals. But in time, it's something that's very dramatic and something that is really it changes everything for both the patients there as well as the bedside staff. And I think that in terms of what our roles and opportunities are in telecritical care, a lot of people, and including myself, like in the beginning, I thought it was just this one homogenous kind of thing that you just provide the service. It doesn't matter what type of hospital it is, and you get the outcomes, hopefully, that are better. But over the decade, I've really started to understand like how you really need to build almost like a custom product to the ICU, to the HSO, to that the community that you're serving, and whether or not it's like an academic or a community hospital. Is there an intensivist there? Is there not? Are there other things outside of the ICU that you can be doing to basically add value, whether particularly in the name of triage, or can you build collaborative projects with each individual ICU. So it's a little bit more heterogeneous in terms of every ICU has a pain point, has something that maybe they're not as good at. So is there a way that we can help them be better at that thing that they're struggling with? And then again, even in terms of like the triage perspective, once you're doing everything that you can within the ICU, well, critical care doesn't just occur in the ICU. As we know, as emergency medicine physicians, like it starts like basically as soon as the patient has an issue at home and from a EMS ride and then in the ED and whether they're on the floor, then coming to the ICU, critical care is not geography based. And so whether or not we can use telemedicine, use the technology to get to that patient as soon as possible to give them an intensivist who's thinking with a critical care mindset, hopefully to deliver more value. And this was a study that we published a couple of years ago now, kind of starting to think about, well, if we're really at just our main flagship hospital like BJH, where there are intensivists and fellows and APPs, and like there's every consultant under the sun that you could possibly imagine. Like, how are we going to provide value here at such a well-staffed hospital with incredible processes? And what we decided to look at was like, looking at our Apache scoring system and saying, hey, well, basically, maybe what we need to do is focus our attention again on the outliers. Like looking at our, basically each little circle there is a diagnosis group that basically says, hey, here at Barnes, like these are probably, diagnostic subgroups that you guys don't do as well with. And then maybe if we focus our attention and our nurses and our docs' attention with more frequent rounding and we kind of identify them early on in the course in terms of when they're admitted, like, hey, this is a worrisome diagnosis, a worrisome opportunity area for us. If we focus on them, maybe we can actually help to improve their outcomes. Because again, like in a general sense, across the board, what we found in our study here that we published is basically yes, like overall, both pre-telecritical care and post-telecritical care from our intervention standpoint we're not really dramatically impacting hospital mortality. But if we just look at those high risk outliers, we do have an ability to improve those patients' outcomes with more frequent rounding and more frequent attention. But then we also like are not able to move the needle as much in terms of the general non-high risk group. Hospital length of stay, which many people want to focus on for telecritical care, it's really never been shown to improve. And I think that's really just a combination of many, many things in terms of being able to, it's not that the patient isn't ready to leave the ICU, is that there's no downflow availability. There's no floor beds. And so that's something that, from my standpoint, is very difficult for me to impact. And even if we then start to branch out to like our community hospitals, where we initially started at just big barns, and then we said, hey, well, once we got the contract to go out to all of our basically BJC community hospitals, pre-implementation and post-implementation with Alton, St. Pete's, all of these, these are much more smaller community hospitals. Some have intensivists, but many of them don't. We started to look at basically how are we doing there, and I think as you might expect as well, like I would say is like, hey, well, now our case mix index is up. The patients are sicker, but our mortality is actually down pretty dramatically, as well as our mortality index. And so we're really able to kind of look at our community hospitals, keeping sicker patients there. Yes, their length of stay is often higher at these community hospitals now, but that's not necessarily a bad thing for them, as basically they're interested in having patients stay there longer from a revenue standpoint, as long as their outcomes are equally as good, if not better. And so I really think that yes, it's multifactorial. It's not just individually the telecritical care operation that was really like 100% exclusively impacting this. But at the same time, I do think we had a dramatic impact as our ability to like get into the weeds with a lot of these community hospital patients, bring best practice standards, bring like daily virtual rounding, focusing on these patients 24/7, 365. And hopefully, like really starting to show our value even in the non Big Barnes Hospital academic center. And so I kind of looked at that like, wow, that's really interesting, like how we're able to impact academic versus communities, small, large HSOs, as well as intensivists versus non-intensivists. And, a lot of ICUs would come to us initially kind of, well, I have an issue with this. We want to kind of impact this. And so we started to take on like more collaborative projects across our system. One of the first ones, honestly, being primarily during COVID, as I'm sure many of you guys had that issue as well as just capacity. And initially here, like, in January 2020, all of our patients, basically everything, every single outside hospital transfer was coming to Big Barnes. But then once we got on board and we had a much more bigger vision of where the open beds were in the system and what each HSO could handle, we started to distribute patients to some of our smaller hospitals that we thought that they could handle and that we could also help them manage. And so as that light green here increases, it's kind of some of our more medium-sized HSOs within the BJC system, really trying to drive them more volume to keep, our Big Barnes Hospital more free for the sickest of the sick patients. And really trying to level load the system capacity through distribution and prevent basically patient leakage to outside hospital systems where we lose revenue. And so in the total, like kind of starting to see, hey, like how do we, keep more patients in the BJC system so that again they don't leak out of the system. And that was something as well from a collaborative perspective with our transfer center was something that we felt strongly about that we could help do. And I think more from a metric standpoint, we've been able to show that, as well as we're getting ready to publish this particular QI kind of project where, from an ER standpoint, we constantly are having ED boarding patients, and a lot of our issue is that as an ER doc myself, I have to call around to all the different units to figure out like, well, like, do you have a bed? No, like, can you call them? And it's just very frustrating. It's time consuming. It's not efficient. And so we basically task that, to the Tele ICU, telecritical care provider who has a vision, who has a board of, knows where all the beds are. And so if that open bed is not available, or sorry, if that expected bed is not available to the ER patient, they just make one phone call to the Tele ICU who then hunts for the bed, figures out where the patient's going to go, overflows the patient sometimes, maybe to a unit where they weren't intentionally going to go to, all in the name of efficiency to basically get patients out of, the ER faster. And we kind of has started this triage pilot, which is now completed. And we really were just kind of trying to understand like what kind of impact, even though it's sometimes hard to measure, in terms of our ability to get patients through the ER quicker. And that is particularly in that 90th percentile, the patients that are waiting for a tremendously long time, hours and hours and hours. Those patients in that kind of outlier group, we were really able to drive down the minutes that they stayed in the ED. And if you kind of multiply that times the number of patients and then hours throughout the course of a year, it really adds up to a lot of bed capacity, which we're going through that statistical analysis right now to publish in terms of the telecritical care, really getting involved with ER triage for ICU boarders. And usually another project that I'm particularly proud of was a pressure injury project that most HSOs, like, that's one of the number one things that the C-suite leadership wants driven down from a reimbursement standpoint. It's pressure injuries. Pressure injuries. You have to, find and document and avoid pressure injuries because we get graded on those and reimbursed based on those. And so it's just always been a major issue for our health system. And I kind of wake up every day asking myself, like, well, how can telemedicine fix this or help solve this? Maybe it can't fix it, but can it improve the issue that we're facing? And basically, from a pressure injury standpoint, a lot of people laughed, to think, well, you can't do anything from a telemedicine standpoint. But if you really dig into a lot of the data, it's like, well, okay, like, some of our best outcomes are when two nurses actually do a skin assessment. And if two nurses do the skin assessment, they don't miss things. And the sooner that you actually get a wound consult nurse initiated, if you do find a wound, then it usually leads to better outcomes. And so the problem, as everybody faces, is that, well, there's not enough nurses and they're too busy and they don't have two RNs all the time to basically do these skin assessments. So, we said, hey, like, why can't the Tele ICU do this? We'll be the second RN. And so that's kind of what we looked at to say, hey, well, you'll hit the button, the bedside nurse can help roll. We can use our camera to like help look for wounds, document the wounds for the nurse, get that wound consult nurse consultation started as soon as possible. Go through a checklist manifesto, making sure that we're doing all the things that we know improve outcomes from a pressure injury standpoint to avoid worsening pressure injuries, but most importantly as well to identify those pressure injuries on arrival so that we don't get dinged for them later. And the trends basically, as we did this study for a couple of years that we just published maybe a few months ago, were pretty dramatic in terms of the hundreds of percents of increase that we were able to basically do from a documentation standpoint on pressure injuries, getting our wound care nurses involved, using the Tele RN skin assessments, upwards of, or making sure that there's a 2 RN skin assessment, 90+% of the time and translating again into millions and millions of dollars, which basically like pays for the annual cost of the program itself, just through an improvement in pressure injury prevention or at least identification. And so these kind of things I think are really important in terms of thinking critically and using new technologies to solve or help solve and help reduce like, big problems that everybody has in their health systems. One other collaborative project, as well as like in terms of the liberation bundle from SCCM and kind of like focusing specifically on that SBT breathing trial, that we know we got to wake patients up, we got to try to liberate them from the vent as soon as possible. But oftentimes, if you're in a smaller community hospital, you're a hospitalist, this is not at the forefront of your thinking. You don't know about this. You prefer your patient to be sedated, to be, calm, and, it's just easier on you. But that delays, increases their ventilator days and complications. And so have to sometimes protocolize this care, but then it's, everybody's all about it for a month. But then, staff changes, like the enthusiasm for like following the bundle and the protocol falls off. But that's what Tele-ICU can bring because we're a smaller operation. We don't have as much turnover. We build it into our workflow, and we kind of can make sure that the bedside is doing what asked of them every single day. And if they're not, we can remind them or do it for them. And so that was always my thesis in terms of, well, I really think that we can impact the bedside care and the use of the SAT, SBT component of the Liberation Bundle through telemedicine. And so, again, we're writing this up for publication as we speak, but basically kind of just doing the step wedge design where I came up, with a much more defined SAT, SBT protocol, put it into Epic, got it basically built into there, and then in a stepwise fashion, kind of introduced the protocol along with telemedicine support throughout different periods of time, as well as kind of doing some Epic enhancements to basically see, can we encourage and get the bedside to do this on a more frequent basis with hopefully at the end of the day, leading to lower vent days, complications, etc. And using our tele RNs to hopefully really drive this process. And throughout that time, our SBT, our respiratory therapists, as you can imagine, like this is just built into their daily workflow. They are incredible at it. They're doing it 90+% of the time. It's the SAT in terms of waking patients up that often is not done as frequently because people are nervous or they're worried or they're not sure. But really protocolizing this and then reminding them, hey, we should wake this patient up. They meet criteria, at least to wake them up, not to extubate them, just to wake them up, is important. And we showed that over time that yes, through that green line there, that we can really start to improve our SAT compliance. And then we'll look to see as we're looking statistically in terms of ventilator days, which are multifactorial, whether or not there'll be impact there. But we know it's best for the patients. And what we particularly find is maybe not too surprising is that, again, at these smaller community hospitals where there isn't a bedside intensivist, the Tele ICU can really dramatically improve your ability to do this protocolized care, as well as kind of using the EHR to its the fullest extent, which oftentimes, health systems don't do because it takes a lot of work to build the right product into your EHR. I would say something that I'm excited about in the future here that we're doing as well is once we've now kind of taken care of all from the ICUs. We're covering all the ICUs. We're doing as much as we can in the ICUs, but I like to bring critical care to the patient, and so we're really now kind of bringing our mobile cart service to life, where they're bringing a telecritical care consult to the floors, to the ER, wherever we can, basically to initiate critical care as soon as possible. And we just published this maybe a month or two ago in terms of our ability to say, hey, this is a feasibility study. Like, do providers like this service? Does it help them? Do we harm patients if we're like trying to, do some basic nuts and bolts critical care, not vents and pressors and everything on the floor, but just kind of second opinion, like a patient's like a little bit, hypotensive, maybe their lactate's up a little bit. Can we institute, care there earlier? And yes, we can. Our providers loved it. We were not harming patients. They don't all go to the ICU after we sign off. And so we're really interested in bringing this model, again, to the floors, to the EDs across our system so that we can start, providing critical care as soon as possible, not to when they come up to the ICU. And there's just like tons of stuff that we want to do, even moving forward in terms of offloading, the bedside with medication verification, where the nurse doesn't have to leave the room and go, find another nurse for a med verifying, and maybe the hundreds of thousands of hours that that can potentially save, across, your healthcare system over the year, and starting to get a little bit more into the weeds on sepsis, PACU patients that are boarding that we have an issue with at our institution, as well as what I mentioned as well with our ICU border situation, and not leaving those patients just in the ER, not necessarily languishing, but they just can get overlooked as you're dealing with a STEMI and a stroke and a trauma, and yet you're on the vent and you have ARDS in the ED, and we need to get you basically,
I'm
optimal
on a
health care
Zoom meeting.
even there.
I'm on a meeting.
Who is in charge or
As I
responsible?
finish up here, basically, I wanted to like at least have a
Mark
mention
Palazzo.
of the
Marco.
fact that telehealth isn't just relegated to telecritical care. I strongly encourage any ER physician out there to really think about, how can we bring telehealth to the emergency department? This was something that I was passionate about during our COVID operation, where we stood up basically a WashU EM telehealth operation. Unfortunately, we did have to shut it down, just as new leadership, finances, cut costs, like all those kind of things. It was brand new, and I think that from a perspective there, like our model could have been a little bit more optimized from a cost perspective. But for the short period of time, 6 months to a year, that we were able to do it and provide, basically. More urgent care, virtual care kind of to patients, as well as, again, trying to do triage before the patient hit the ER doors and saying, hey, like you should maybe go to this hospital, or you can go there, or we can get you just follow up with your primary care doctor. You don't need to come to the ER. Like all these things that we were doing were just, I loved it. It was fascinating. And I really think with a larger scale operation and over time, you could really make a dent in terms of basically your ability to appropriately triage patients and level load your system, as well as many other things, in terms of hoping to avoid those rural hospital transfers if they're not necessary, that clog up your system, focusing on those time critical diagnoses with a board certified EM physician, and even standardizing care in the ERs along with your critical care colleagues for lung protective ventilation, making sure that patients who get paralytics are sedated, your geriatric, your trauma care, bringing out some of our subspecialists to these rural hospitals in the ER for toxicology, substance abuse, ultrasound, you name it. There's opportunities really to monetize uh, opportunities that we as EM physicians have to expand out into our community. And I've written about this in a couple of EM journals over the past few years, which I'm excited, hopefully in the next few years, to start up again. And so as I finish up, this whole like basically process is, what I try to look at as a digital strategy, from a crisis to a cure. I want to be with that person. I want to be like virtually holding their hand throughout the process, from the time that they have an incident to when they get into our hospital system and even till after they leave from a, post-hospital recovery perspective. As my father actually had a pretty bad case of post-intensive care syndrome. But again, that was something during the pandemic that it was very difficult for him to get help. Everything was closed. They weren't traveling anywhere. It was complicated. And so, it's something as well that I had a small grant where I basically created a COVID-19 virtual post-intensive care syndrome clinic where, basically we just met with patients virtually over Zoom after they were discharged and got home. And we had a dietitian, a pharmacist, an intensivist, PTOT, social worker. Like we had all these providers basically help, nurses, basically everybody trying to see how the patient was doing, how they're recovering, where they're lagging behind, mental health, physical health, all these things. That was really incredible. And again, another one of those things that I'd like to do at a larger scale operation when the moment is appropriate. So it takes a huge team in order to do all this. And we've finally been able, to kind of move into our a bigger building, a bigger area, just over the past few months. We don't use this entire building, but we went from a very small scale operation and kind of grew exponentially to now it's like this huge operation with a lot of people trying to all basically focus with the patient in the middle. And whether that's a virtual hospitalist, virtual intensivist, virtual telepharmacist, teledietitian, bringing all of these patients, palliative care, all of these things can be done virtually and are really highly scalable and efficient. And we're just now in the process of really expanding our operation outside of BJC, across state lines to Illinois and further into Missouri. And we'll see where we go from there. But bringing on new hospitals outside of BJC with kind of some monetization. As well as just kind of subscription type revenue, hopefully sources. Really trying to, I meet with companies all the time with new products that we can hopefully help institute and integrate into our health system for improved patient care. And finally, my biggest vision is hopefully as I retire, establishing our second command center out in New Zealand, which was one of my favorite vacations of all time. Where, again, they're about 12 hours apart. And Emory does this where they have a satellite center out in Perth, Australia. And so basically, nobody has to do nights anymore because when you're in daytime in New Zealand, you're covering nights. In St. Louis, Missouri. And so that would be the ultimate goal as we grow and get big enough to basically afford that and to make a business case for it that, we should be able to eliminate night coverage, for a lot of our providers, which again, wellness, retention of staff, recruiting staff, all these things are incredibly important to your operation and your HSO's future. So I truly believe, telecritical care, digitization, healthcare, like this technology, it is the future. It's here. It's only going to be more necessary in the very near future. And I'm excited about it. I see the impacts almost every day, and I'll be happy to take any questions that you have after I finally say go Bills. Thank you.
Well, that was a very exciting lecture. Your passion is very evident. I have three major questions.
Yes.
One, I mean, in 1999, the To Earth Human Report came out, and there are lots and lots and lots of errors that were made. So huge systems were put into place, including reducing training hours, which meant you needed more residents. So there's a cost elevation there. And then after all this time, since 1999, the errors have not diminished. And so the question is, what is the potential for error here when you're more remote? And it's kind of frightening. So that's one question. The second question I have is, how will this apply to third world where the need is so much greater and their ability to support it is going to be much, much, much smaller. That's a huge concern to me. And what will it do to the patient-physician interaction? I mean, your dad obviously is going through just post-trauma disaster. I mean, near death and having what I call a tremendous isolation in the hospital, constantly seeing strange faces. So there is no sense of safety,
Yeah.
except that you have to trust the people coming to see you. So, how would we cope with that? I think one of the things you did show was having the post-COVID group come together so that they all see that I'm not the only one, and so and so's like I am, and they are a little bit further along and better, so I can see both potential bad and potential much good that can come from that kind of thing. But
Yep.
thank you for your very passionate talk.
Yeah, I'll start with the last question there. Like in terms of that virtual presence, what we find is that, patients just want expertise at the time of care. So it's 2 o'clock in the morning, they're in a small community hospital, and your face pops up on camera. They love it. They just are so happy and over the moon that there's somebody there with expertise that can take care of them and put in orders, and they just feel confident that they're being well taken care of. Even though you're not there physically, it's either that or nothing. And so they just love it. I've actually had compassionate care and terminal extubations, goals of care discussions with patients that I just met with their families over the camera at 2 o'clock in the morning. And they love it. Like the experience that they send us is like, thank you, thank you, thank you, thank you. And you would think that there's no way that they could tolerate just talking to a person on camera, but they love it. And so that I personally find from a compassion, the human interaction standpoint, is the only thing that I've ever felt is like they love it. I've never had really a negative interaction with a bedside family member in terms of like me not being there physically.
So do
Um,
you introduce the patient to this expert? So they
yes.
right away are they're biased towards this expert must be
Yep.
super duper, and therefore,
It's like, hey, you're getting a wash you intensivist at 2 o'clock in the morning who is there solely focused on your loved one. And they're just like, great, like awesome, so happy. I think one of your other questions was about the errors. That's always been a tricky one. I think that the most that we can do is like if you add more interns, you're probably not going to reduce errors as much. So what we're trying to do is add basically an intensivist, a board certified intensivist in more places where they didn't exist before. And we're showing that we're reducing mortality, morbidity, and complications related to that, as well as like bringing just our kind of protocolized, standardized care that we know improves outcomes. And we also do that Swiss cheese model to reduce errors and complications. Hey, your heparin's like at quadruple the dose. We catch that. Hey, all these kind of things where it's like, oh, your antibiotics are inappropriately dosed. Hold the bank, like all these kind of things that we hope will reduce complications again through high level expert care. Even though it's not more voluminous, it's actually just like the expertise is higher, as well as infusing technology and AI tools that like generally make less mistakes as they get better to hopefully improve care. And I think I forget your second question,
well,
which
well,
third world countries. Yeah, that's something that I do a little bit of. That I hope to bring for our program here in the near future is every now, like maybe a couple of times a year, instead of traveling to Kenya and Africa and South America, I actually just do telemedicine consultations for these providers in these third world countries to provide like a lecture. I'll round with them virtually. So it's not as high fidelity of an operation as we do, but I think it can get to that basically in no time. So it's crazy that you can be in Kenya and get a WashU intensivist, kind of like helping lead rounds and answer some questions that they may have. As you're learning as well about diseases that you've never seen before, and they don't have the antibiotics that you typically expect. So it's fascinating, it's challenging. But again, I think it democratizes access to high quality care. And I've seen it with my own eyes, and that's why I'm so passionate about it.
is there any liability? Because clearly you're not practicing in that state.
Yeah, we've,
So how do you handle that liability?
I've asked a lot about it, but there's nothing written down and again, a 10-year, there's always liability. Like if I'm treating a patient and I'll focus mostly on America here because in America, like the liability is much more clear cut. Like if I order a potassium bolus that kills a patient, even though I'm the telecritical care doctor, I'm liable for that. However, like we trust our providers to be good doctors, do what they would do at the bedside. But again, there's way more checks and balances when there's more intensivists kind of like watching the patient. And so, God forbid that we haven't had any issues with that thus far. Yes, you are liable, even though you're not physically there. But in these rural countries, third world countries, like they don't have any lawsuits or litigations or anything like that because there's just no money for that. Their judicial system isn't set up for that. So they're just so thankful, that you're there just to try to help out.
Chris, I'm going to step in for Evan. We're running a little bit over time, but I just
Yeah,
want to thank you so much for speaking to us and giving us this great overview of what telecritical care is and some very creative and amazing uses for it. So thank you so much for taking the time and speaking with us today.
absolutely. It's been my pleasure. I love it. It's just again, it's a hobby, a passion, and a job. All three. So
Thank you so much.
Thank you. Happy Thanksgiving, everyone.
you too. Thank you.
And you play the guitar. Is it
Yes, I
classic?
do. I play the guitar and I love the Buffalo Bills. So
Classical?
sorry.
Classical guitar?
No, just kind of like strumming around on my own, nothing like too serious, so just a little bit of takes the edge off.
Yep, it sure does. You have to concentrate on the music and
That's right.
nothing else can intervene. Well, happy Thanksgiving, everyone. Thank you.
Take care. Thank you.